Welcome to the Deep Dive. We're the show that tries to cut through the noise, look at the data, and really give you the essential insights. Today, we're digging into something that, well, it touches all of our lives, but maybe we don't think about how it works. Healthcare report cards.
Right. Those rankings you see for hospitals, sometimes even individual surgeons. Who's the best? Where are the highest success rates?
Exactly. And these aren't just, interesting lists. They actually shape where patients go. They drive improvements.
Yeah.
Sometimes they even affect how doctors get paid.
They have real consequences.
And when you think about these kinds of really rigorous evaluations, one that often comes up is the New York State Cardiac Surgery Report Card, the NYS one.
Yeah, that one's pretty well known, kind of seen as a benchmark for its methodology, how carefully it's done.
Which makes it perfect for us today. But here's the big question, the one we really want to unpack. How reliable are these rankings? I mean, what if the map itself, the way you calculate the scores, completely changes who looks good and who looks bad?
That's the core of it.
So our mission today is to sort of pull back the curtain on that statistical black box. We're going to look at how different statistical methods can really shift these healthcare rankings using that NYS report card as our main example.
And figure out what that means for you as a patient or just anyone trying to understand healthcare quality.
Okay, so let's start with why this is so tricky in the first place. Ranking hospitals or surgeons. It's not straightforward, is it?
Not at all. It's incredibly complex, actually. You can't just look at the raw outcomes, say mortality rates.
Because patients are different.
Exactly. Patients walk in the door with completely different health backgrounds, different levels of sickness. Some are much higher risk than others.
Right, so you need to account for that.
Yeah.
This is risk adjustment, yeah.
That's the term, risk adjustment. It's basically trying to level the playing field statistically.
So you're trying to make sure that, say, a surgeon who takes on really complex, sick patients isn't unfairly penalized if their death rate is higher?
Precisely. Or that another one treating healthier patients doesn't look artificially amazing just because their patients were lower risk to begin with.
Okay, makes sense.
It's about asking, okay, given this specific group of patients, what mortality rate would we expect? And then you compare that expected rate to what actually happened, the observed rate.
But you said there's a risk to risk adjustment itself.
Yes, that's the tricky part. Different statistical models, even if they're all trying to adjust for risk, they don't always agree on the best way to do it. There isn't one single perfect formula everyone uses.
Okay, so it's like judging chefs, but one gets prime ingredients and the other gets stuff that's about to spoil. You need to adjust for the ingredients before you judge the cooking.
That's a great analogy. And if different people have different ways of adjusting for those ingredients, well, you might get different rankings for the chefs.
So this study you mentioned, Guans et al., from 2006, they tackled this head on.
They did. They wanted to test how robust the NYS cardiac surgery report card was, specifically for CABG surgery, coronary artery bypass graft.
CABG, right.
They basically asked, if we use different statistical methods, do we end up flagging the same surgeons and hospitals as high or low performers?
And they had a good chunk of data to work with.
Oh, yeah. It was impressive. Over 51,750 patients. This was for isolated CABG surgeries in New York State between 1997 and 1999.
And the overall death rate for that group in the hospital?
2.20%. And yeah, the outcome was clear. In-hospital mortality. Did the patient die before leaving the hospital or not?
Pretty unambiguous outcome. But getting from that outcome back to judging the provider, that's where the stats come in. What were the main approaches they looked at? Can you walk us through them without, making our heads spin?
I'll try. Think of it like different camera lenses. Each one gives you a slightly different view of the same landscape.
Okay, I like that.
So first, there was the NYS DOH standard approach. This was the method the New York State Department of Health actually used back then.
The official one.
Right. It uses standard logistic regression and calculates that observed to expected ratio. We talked about the OE ratio. How did the provider actually do compared to expectations?
And how do they decide who was an outlier? Like unusually good or bad?
They used confidence intervals, CIs, calculated using something called the Poisson distribution. Basically, it's a statistical way to estimate the range around that OE ratio, assuming outcomes, like deaths, are relatively rare events following a certain pattern.
Okay, so it makes an assumption about the pattern. Got it. What other lenses did they try?
Then they looked at fixed effects models. Imagine each hospital or surgeon has their own unique sort of constant effect on outcomes. Fixed effects tries to estimate that specific individual effect for each provider.
Like measuring the exact skill level of each chef separate from everything else.
Kind of, yeah. It tries to isolate that provider-specific component. Then, in contrast, you have random effects models, sometimes called random intercept models. These treat the provider effect differently. Instead of a fixed value for each one, it sees them as random variations drawn from a larger pool.
So less about provider A being exactly this good and more about them being part of a general distribution of provider quality.
Exactly. And the key assumption here is that these random provider effects are independent of the patient's risk factors, like assuming a chef's skill has nothing to do with the ingredients they get.
Okay. That sounds like a potentially big assumption in healthcare. We'll probably come back to that.
We will. It's important.
What else did they vary? You mentioned confidence intervals earlier.
Right. They looked at two main ways to calculate those CIs. Remember, CIs tell us how precise our estimate is?
The error bars, basically.
Sort of, yeah, the range of uncertainty. First was the parametric Poisson distribution method, the one NYS DOH used. It assumes the data fits that specific Poisson pattern and treats the expected rate as fixed. The other was non-parametric bootstrapping. This is much more flexible. It doesn't assume a specific pattern. Instead, it resamples the actual data thousands of times to build up a picture of the uncertainty. Crucially, it accounts for uncertainty in both the observed and the expected rates.
Okay. So bootstrapping is like, it doesn't assume it knows the shape of the mountain range beforehand. It maps it out by looking from lots of slightly different angles.
That's a really good way to put it. It's more data-driven about uncertainty.
Seems more honest, maybe, about what we don't know for sure.
It's certainly considered more robust in many situations. And finally, they looked at shrinkage estimators.
Shrinkage. Sounds like laundry day.
Huh. Well, it's mostly used with those random effects models. Imagine you have a surgeon who only did a few operations. Their results might look really amazing or really terrible just by chance, right?
Yeah, small sample size problem.
Exactly. Shrinkage estimators basically shrink those potentially extreme results back towards the overall average. It pulls them closer to the middle.
Why do that?
The idea is to get more stable estimates, especially for low-volume providers. It assumes extreme results are partly just random noise and tries to smooth it out.
Okay, so we have all these different lenses. The original DOH method, fixed effects, random effects, different ways to calculate uncertainty, and this shrinkage thing.
Yeah.
The big question then, did it matter? Did switching lenses change the picture of who was an outlier?
It absolutely did. And this is where it gets really interesting, especially when looking at the surgeons, because there were more of them, 138 surgeons versus just 33 hospitals. More data gives clearer results.
Okay, so what did they find for the surgeons?
Well, first, some good news for the original method, in a way. When they just looked at the OE ratio with the standard Poisson confidence intervals, the NYS DOH's logistic regression, the fixed effects model, and the fixed part of the random effects model all pretty much agreed.
Agreed on who the outliers were.
Yeah, they showed near perfect agreement. The technical measure, the intraclass correlation coefficient, or ICC, was 1.00. Perfect agreement.
Wow. So for this specific type of surgery, CABG, those robust methods basically saw the same surgeon standing out, good or bad. Why?
The study suggests it's because the individual surgeon's unique contribution to mortality, after accounting for patient risk, was actually pretty small for CABG during that time. The ICC for the random effects surgeon part was only 0.059. That's tiny. It means most of the variation in outcomes wasn't down to the specific surgeon, but other things, patient factors, maybe team factors, random chance.
So in this context, the chef's skill, as it were, wasn't the dominant factor. That's interesting. Maybe reassuring for the original report card, at least for CABG back then.
It suggests the original method wasn't wildly off base for this specific situation because the thing it might have struggled with, surgeon variation, wasn't huge to begin with, but that's where the agreement ended.
Okay, so where did things start to look different?
Big time with the shrinkage estimators. Remember how they pull extremes towards the average?
Right, the laundry day effect?
Yeah, exactly. They identified the fewest outliers. Basically, they made the high performers look a bit worse and the low performers look a bit better. It smoothed everything out.
So it gives you maybe a more stable number. The confidence intervals might even be narrower, but it might be hiding the real stars and the real strugglers. It sort of paints everyone gray.
That's the trade-off. Precision versus potentially masking true variation. It introduces a bias towards the average.
Okay, so shrinkage found the fewest outliers. What found the most?
The bootstrapping confidence intervals. Using that flexible, data-driven way to calculate uncertainty, it identified the greatest number of outliers.
Why? Because the intervals were narrower.
Precisely. Bootstrapping, by accounting for uncertainty more comprehensively, actually resulted in narrower confidence intervals compared to the standard Poisson method.
And a narrower range means it's easier for a surgeon's performance to fall outside of it, to be flagged as statistically significant, right?
Yeah, exactly. The p-value they reported, less than 0.001, means this wasn't a fluke. Bootstrapping was significantly more sensitive. It had more statistical power to detect genuine outliers. It provided a sharper lens.
Okay, that's a massive difference then. Depending on your statistical choices, shrinkage versus bootstrapping, you get wildly different numbers of surgeons flagged for performance. What about the hospitals? You said there were fewer of them.
Right, only 33 hospitals compared to 138 surgeons. They saw similar trends, like shrinkage identifying fewer outliers and bootstrapping more. But because the number of hospitals was smaller, the results were less statistically stable or powerful.
So harder to draw firm conclusions at the hospital level. A few unusual cases could swing a hospital's rating more easily.
Exactly. It just highlights that sample size really matters in these rankings. More data generally means more reliable results.
Okay, stepping back then, this isn't just about numbers. It plugs into a bigger debate in health services research, doesn't it? What's the core tension?
The core tension often comes back to that assumption we touched on: the independence of patient risk and provider effects.
The idea that a surgeon's skill isn't related to how sick their patients are.
Right. Standard logistic regression, like the original NYS-DOH method, and random intercept models generally assume they're independent. But in reality, that's probably not true, is it?
Yeah, it seems unlikely. Top surgeons probably get tougher cases referred to them, right? Or certain hospitals might attract sicker patients.
Exactly. And if that assumption of independence is wrong, if skill is correlated with risk, then those models can give you biased, inconsistent estimates of quality. They might not be telling you the true story.
Which models handle that correlation better?
This is where fixed effects models often shine. They don't rely on that independence assumption. They can give you unbiased estimates of the provider effect, even if it's correlated with patient risk factors. They're often seen as more robust when you suspect that kind of correlation exists.
So fixed effects is like the cautious detective. It doesn't assume anything, just looks at the specific evidence for each provider.
That's a good way to think about it. But then you have that trade-off again with something like shrinkage.
Right. Shrinkage gives more precision, smaller error bars.
But at the cost of potentially introducing that bias, pulling everyone towards the average, maybe misrepresenting the truly exceptional or the truly problematic performers. It's precision versus accuracy in a way.
So why should you listening care about all these statistical details? It sounds pretty academic.
That's really not.
No, because these report cards, they have real-world impact. They influence where you might choose to go for surgery. They affect which specialists your doctor recommends.
And increasingly, they're tied to money through pay for performance. Hospitals and doctors can be rewarded or penalized based on these scores.
So being labeled, maybe incorrectly, as high or low performing, that has huge implications for reputations, for finances, for patient access.
Absolutely. It underlines that the way we measure quality is critically important, and this study showed how much the measurement can change depending on the tool you use.
And it seems the level of disagreement between methods depends on how much the provider actually matters for the outcome and how tangled up their effect is with patient risk.
Exactly. In the CABG study, the surgeon effect seemed relatively small, which is why some methods agreed well. But for other conditions, other surgeries, the surgeon or hospital might play a much bigger role, or the correlation with risk might be much stronger.
Which would make the choice of statistical model even more critical in those cases.
Definitely. The stakes get higher.
Okay, so wrapping this up, the big takeaway here seems pretty clear. A seemingly simple report card hides a lot of statistical complexity. And different statistical methods, different lenses, can give you significantly different pictures of who the quality outliers are, even in a well-regarded system like the NYS cardiac surgery one.
Yeah, the choice of methodology really matters.
Which leads straight to the study's main conclusion, and really our message to you. Anyone creating these public reports needs to test how sensitive their results are to the statistical method they choose.
They can't just pick one and assume it's right. They need to explore, to understand the potential biases, and be transparent about it before releasing rankings publicly.
It calls for more rigor, more transparency behind the numbers.
Definitely. And maybe a final thought to leave you with.
Yeah.
If the statistical lens can shift our view of something like surgical quality so much, what does that mean for all the other ranking systems we encounter? Schools, products, maybe even performance reviews at work.
Things that also rely on complex data and models.
Exactly. Are there other hidden methodological choices shaping how we perceive quality or performance all the time, maybe without us even realizing it? Are we sometimes celebrating the average or missing true excellence just because of the math being used?
That is a really provocative thought.
Yeah.
Makes you want to look under the hood of any ranking you see.
It's worth asking the question.
Well, thank you for taking this deep dive with us today. We hope it encourages you to think critically about the data you see, the rankings you encounter, and the methods quietly shaping our understanding of quality everywhere. Until next time, keep digging.